Hello everyone. I am Dr. Amandeep Ludar, Senior Resident in ENT Department, Bharati Hospital, Sangli. Our topic of discussion today is tonsils. Before we begin, let us understand what is Walder's ring. Mucosa associated lymphoid tissue in subepithelial layer of pharynx is aggregated at the entrance of aerodigestive tract and are collectively called Walder's ring. It consists of adenoids, tubal tonsils, palatine tonsils, lingual tonsils, lateral pharyngeal band, and nodules on the posterior pharyngeal wall. It is important to know the difference between adenoids and palatine tonsils. Adenoids are single in number, situated in the nasopharynx. They have furrows instead of crypts, do not have a capsule. They have a lining of ciliated columnar epithelium and they are usually absent in adults. In contrast, tonsils are two in number placed on lateral surface of oropharynx. They have crypts and are encapsulated, lined by stratified squamous epithelium and persist even in adults. Palatine tonsils, or commonly addressed as tonsils, are ovoid mass of lymphoid tissue situated in the lateral wall of oropharynx, that is the tonsillar fossa. Palatine tonsils develop in the second pharyngeal pouch. Usually during development, the second pharyngeal arch overgrows the second, third, and fourth pharyngeal cleft, forming the cervical sinus, which eventually resorbs. Sometimes the sinus persists and give rise to cervical cyst along the anterior border of sternocleidomastoid. This cyst, when communicates with the bed of palatine tonsil, it is known as internal bronchial fistula. When it communicates with the skin, it is known as external bronchial fistula. Epithelium of the second pharyngeal pouch proliferates to form solid endodermal buds, growing into the underlying mesoderm. These buds give rise to tonsillar stroma. Central cells of the buds die later and slough, converting the solid buds into hollow tonsillar crypts, which are infiltrated by the lymphoid tissue. Tonsils are ovoid in shape and are present on the lateral wall of oropharynx between the anterior and posterior pillar. It has two surfaces, medial and lateral, and two poles, upper and lower. The size of the tonsil varies as per age, individuality, and pathological status of the patient. It increases rapidly in the school going children. It reaches its maximum size at the age of puberty. It is very important to know the anatomical relation of tonsil in view of surgery. Anteriorly, tonsil is limited by the anterior pillar formed by the palatoglossus muscle. Posteriorly, it has the palatopharyngeus muscle which forms the posterior pillar. Superiorly, the medial surface of tonsil upper pole has semilunar fold between the anterior and posterior pillar. This fold encloses a potential space called as the supratonsillar fossa. Inferiorly, the lower pole of tonsil is attached to the tongue. There is a triangular fold of mucosal membrane extending from the anterior pillar to the anteroinferior part of tonsil. This fold encloses a anterior tonsillar space. Tonsillolingual sulcus is a space between the tonsil and the tongue. It is a common site for carcinoma. Lateral surface of tonsil is covered by a well-defined fibrous capsule which is separated from the bed of tonsil by a loose areolar tissue that allows easy dissection during tonsillectomy. Some fibers of palatoglossus and palatopharyngeus muscle are attached to the tonsillar capsule. Superior constrictor muscle, glossopharyngeal nerve, and the styloglossus muscle form the bed of the tonsil. Lateral to the superior constrictor muscle lies the facial artery, submandibular gland, posterior belly of digastric muscle, medial pterygoid muscle, and the angle of the mandible. The medial surface of tonsil projects into the oropharynx. Non-keratinizing stratified squamous epithelium lines the medial surface of tonsil and dips into the tonsillar mass to form crypts. Opening of these crypts can be seen on the medial surface of tonsil. Crypta magna or the intratonsillar cleft is situated near the upper part of tonsil. It is very large and deep, and it represents the ventral part of second pharyngeal pouch. Secondary crypts arise from the main crypt within the substance of tonsil. Crypts may be filled with cheesy material which consists of epithelial cells, bacteria, food debris, and can be expressed out with pressure over the anterior tonsillar pillar. The main artery of tonsil is the tonsillar branch of facial artery. Other branches of external carotid artery that supply the tonsil are ascending pharyngeal artery from external carotid artery, ascending palatine artery branch of facial artery, dorsal lingual branch of lingual artery, and descending palatine branch of maxillary artery. Veins from the tonsil drain into the paratonsillar vein, which are present on the lateral surface of tonsil, and drain into the common facial vein and pharyngeal venous plexus, which in turn drain into the internal jugular vein. Palatine tonsils develop in the second pharyngeal pouch. Usually during development, the second pharyngeal arch overgrows. This nerve supply is responsible for referred otalgia, as the glossopharyngeal nerve also supplies the tympanic membrane and the middle ear. The medial surface of tonsil projects into the oropharynx. Non-keratinizing stratified squamous epithelium lines the medial surface of. The functions of tonsil and adenoids are same. They act as protective sentinels against harmful intruders into the air and food passages. The crypts in tonsil increase the surface area of contact with the foreign substances. T lymphocytes in the parafollicular region provide cell mediated immunity against viruses, bacteria, and fungi. Once pathogen enters the lymphoid aggregations, they are taken care by the IgM and IgG antibodies, which are produced by the plasma cells. They also produce antibodies, especially secretory IgA. Epithelium of the second pharyngeal pouch proliferates to form solid endodermal buds, growing into the underlying mesoderm. These are few causes for white spots or membrane over the tonsil. Commonest one being due to trauma and aphthous ulcer over the tonsil. Malignant tumor are rare cause for white patches. Acute membranous tonsillitis is one of the commonest causes for membrane or white patch over tonsil. We will have a detailed lecture for acute tonsillitis later. Today, we will be highlighting few points. Symptoms of acute tonsillitis consist of throat pain, dysphagia, fever, earache, headache, malaise, constipation, and abdominal pain. Signs include coated tongue, halitosis, redness of pillar, soft palate, and uvula. Tonsils will be congested with yellowish patches over the crypts. Diagnosis of acute tonsillitis can be made by rapid strep tests or throat culture. Treatment for acute tonsillitis is antibiotic course for 7 to 10 days with complete bed rest, fluids, analgesics and antipyretics. Vincent's angina usually affects young adults and middle-aged persons. Ulcerative lesions which get covered with necrotic slough can be seen over the gingivae and on tonsils. Usually it involves single tonsil. This pseudomembrane can be easily removed and reveal an irregular ulcer. The incidence of diphtheria has significantly reduced due to immunization. The causative organism is Corynebacterium diphtheriae and it usually spreads by droplet infection. Clinical features of diphtheria shows low grade fever, a dirty gray tenacious membrane over the tonsils which may extend into the soft palate as well as the posterior pharyngeal wall. Removal of this membrane usually leaves a raw bleeding surface. It may also extend into the larynx as well as the nasal cavity. Patients may present with bull's neck, which is because of enlargement of the lymph nodes. Diagnosis can be made by urine examination as well as culture sensitivity of the throat swab. Complications includes myocarditis, cardiac arrhythmias, acute circulatory failure, paralysis of the palate and diaphragm, as well as the ocular muscles, and there may be laryngeal obstruction as well. Treatment of diphtheria includes diphtheria antitoxin or anti-diphtheric serum, which is started immediately on clinical suspicion to neutralize the free diphtheria exotoxin in the body. Dose depends upon the site, duration, and severity of the disease. It is administered through intravenous infusion in saline over a period of 60 minutes. Infectious mononucleosis is caused by Epstein-Barr virus. It commonly affects older children and young adults. Patient presents with fever, sore throat, and exudative pharyngitis. Petechiae at the junction of hard and soft palate are characteristic features of this infection. Serological tests like monospot, Paul Bunnell, and ox cell hemolysis show high titers of heterophilic antibodies. Infectious mononucleosis is a self limiting disease which usually recovers after weeks. There is no role of antibiotics except in case of secondary infections. Ampicillin and amoxicillin may cause salmon colored rash in this condition. Hence, they should be avoided. Patient may suffer from upper airway obstruction due to significantly enlarged tonsils. It is managed with nasopharyngeal airway, high dose of steroids, or by tonsillectomy or tracheostomy. Clinical features of diphtheria shows low grade fever, a dirty gray tenacious membrane over the tonsils which may extend into the soft palate as well as the posterior pharyngeal wall. Removal of Tonsilloliths or tonsillar concretions are calculus of tonsil which may be seen in chronic tonsillitis. The blocked tonsillar crypts cause retention of debris which consists of inorganic salts of calcium and magnesium that result in formation of stones. Treatment is mainly conservative, that is expression of concretions and chemical cauterization of crypts. Tonsillectomy can also be done if the patient complains of persistent pain, halitosis, and foreign body sensation. The main artery of tonsil is the tonsillar branch of facial artery. Other branches of external carotid artery that supply the tonsil are ascending pharyngeal artery from external carotid artery, ascending palatine artery branch of facial artery, dorsal lingual branch of lingual artery, and descending palatine branch of maxillary artery. Tonsillar cyst usually occurs due to blockage of tonsillar crypt and may present as yellowish swelling over the tonsil. It is usually asymptomatic. Patient if complains of any symptoms, it can be simply drained by aspiration or incision and drainage. Stay home, stay safe. Thank you for your patient listening.